Hi there, my highly valued and treasured viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by profession and by training, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare sector workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal treatment of clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy clinical services in your line of duty. So I would like to kindly urge you to sit back and spare me part of your precious time to share some tips for effective clinical pharmacy service delivery in your place of work. Question 1 reads, NNN, a 55-year-old Hispanic female, presents to the clinic for evaluation of her dyslipidemia. She has a past medical history of type 2 diabetes mellitus, and her 10-year atherosclerotic cardiovascular disease risk score is 13%. Her current fasting lipid panel includes total cholesterol of 240, HDL of 48, TG of 682, LDL, you are told the team was unable to calculate, but the direct LDL is 105. My question to you is, which of the therapies listed below would be the most ideal for Lady NNN basing on the above lipid panel? Would it be ezetimibe, colesevelam, fenofibrate, or simvastatin? I'll give you 10 seconds to choose the correct answer. So in my opinion, fenofibrate it would be. Now NNN's TG values are very high, placing her in or at a high risk of pancreatitis, to be specific, and these TGs should ideally be reduced. Now when TGs exceed the 500 milligram per deciliter mark, and especially when they are above the 1000 mark, treatment of the TG becomes the primary goal of therapy to minimize pancreatitis risks in a patient. Of the listed drugs, fenofibrate would be the most appropriate. Now colesevelam, which is a bile acid sequestrant or resin, targets LDL lowering and may actually increase TG values. That is a class effect. The same applies to cholestyramine and cholestyramine, which work in the same way, just as a by the way. Now simvastatin and ezetimibe are both designed to target LDL, not TG at all, but they'll still likely be needed, since our patient NNN would also likely benefit from high intensity statin therapy due to her type 2 diabetes mellitus and the 10-year atherosclerotic cardiovascular disease risk score, which, if I remember well, was above the 7.5% mark. Simvastatin has small TG lowering capability, but given the degree of TG elevation in this patient's case, TG lipid lowering medication such as fenofibrate or any of the fibric acid derivatives would be the most appropriate. Let's move to the next question, please. So ALM, a 55-year-old Kenyan female, presents to the clinic for a follow-up appointment. She has a past medical history of hypertension. Some of her pertinent fasting labs include a C of 250, LDL cholesterol of 180, TG of 200, HDL of 33, and you are told the other labs are within normal limits. Currently she takes a fixed dose combination of lisinopril and hydrochlorothiazide, 20/12.5 to be specific, to manage her hypertension. Now, based on her criteria, you compute her 10-year atherosclerotic cardiovascular disease risk score to be 10.6%, and this lady has a family history of premature atherosclerotic cardiovascular disease. The team discusses about her options with her, and ALM is willing to initiate therapy today. So my question to you is, which treatment option listed below would be the most ideal for lady ALM? Would you opt to settle for ezetimibe 10 milligrams once daily? Would you go for atorvastatin 20 milligrams at night? Would you settle for simvastatin 10 milligrams at bedtime? Or would you go for the high intensity statin therapy using rosuvastatin 20 milligrams at bedtime? I'll give you 10 seconds to choose the correct answer. In my opinion, atorvastatin 20 milligrams at bedtime it is. Now, according to the ACC/AHA guidelines, patients aged between 40 and 75 years without type 2 diabetes mellitus and a 10-year atherosclerotic cardiovascular risk score of between 5 and 19.9% what we call the intermediate risk category, and they should have moderate intensity statins initiated for their therapy. That is, if risk enhancing factors are present. Now, this lady has at least one risk enhancing factor. This is the issue of family history of premature atherosclerotic cardiovascular disease. Then in my opinion, therefore, atorvastatin 20 milligrams would be the best choice, because from that list it is the only moderate intensity statin option. Now, ezetimibe would be a reasonable option if the patient was receiving maximally tolerated statin doses and the LDL levels remained equal to or above the 70 milligram per deciliter mark. Option C, simvastatin 10 milligrams, is what we consider a low intensity dose. Now, option D, which is 20 milligrams of rosuvastatin, is considered a high intensity dose, which is a range between 20 and 40 milligrams of rosuvastatin at bedtime. So that makes me feel B would be the correct answer. Now, in order to identify optimal lipid management therapy, the choice is usually made based on the LDL cholesterol levels, on the 10-year ASCVD risk score, and the presence of diabetes mellitus, or the risk enhancing factors that I've just listed above. Now, if the LDL cholesterol is 190 milligrams per deciliter or higher, a high intensity statin therapy may be initiated without regard to the 10-year atherosclerotic cardiovascular risk score. Now, in the absence of risk enhancing factors, patients with type 2 diabetes mellitus whose atherosclerotic cardiovascular risk falls into the borderline or and the intermediate category, sorry for the slip, may have a coronary artery calcium level measured in order to help drive the decision making. That's just by the way. Let's move to the next slide, please. JSL, a 65-year-old female with acute heart failure, is admitted to your hospital with increasing shortness of breath, decreased urine output, and confusion, altered mental status. Her past medical history includes HalfRef, heart failure with reduced ejection fraction, hypertension, type 2 diabetes mellitus, and dyslipidemia. Some of her home medications include 12.5 milligrams of carvedilol taken orally twice daily, 10 milligrams of lisinopril taken once a day, and she administers insulin glargine, her basal insulin, at a dose of 10 units subcutaneously at bedtime, and she also takes 81 milligrams of aspirin once daily orally. Some of the pertinent labs include sodium levels of 135, potassium of 4.2, chloride of 107, bicarb of 24 with a BUN of 25, and the serum creatinine is 1.8. Some of our vitals include a systolic blood pressure of 68, pretty low, and a diastolic of 42 with a heart rate of 106. The heart is revving pretty fast. The temperature is 98.2 and the respiratory rate is 22. A physical exam is done and it identifies bilateral rails upon pulmonary auscultation, and it emerges she has cool, dusky hands and feet with a +2 bilateral edema. The heart seems to have an issue here. So my question to you is, which of the interventions listed below would be the most appropriate for patient JSL? Would you administer dopamine via continuous infusion, or norepi via continuous infusion, or dobutamine via continuous infusion, or milrinone via continuous infusion? I'll give you 10 seconds to choose the correct answer. Personally, I'd settle for norepinephrine via continuous infusion. Remember, JSL is in what we call a florid cardiogenic shock state with signs of hypoperfusion of her critical organs. Norepinephrine is the preferred agent in severe cardiogenic shock to re-establish perfusion of what we call the critical organs. Then dobutamine can be added for further enhancement of cardiac output. Now, dobutamine will be necessary in JSL's care, but it may not be adequate to enhance perfusion of her critical organs if we opted to use it as monotherapy, so it would not be the best answer. Now, after NE, norepinephrine is titrated to achieve a MAP, or a mean arterial pressure, of about 65. Dobutamine should be titrated to an adequate cardiac index, since we know that it can cause vasodilation via beta 2 receptor activation and reductions in systolic blood pressure, and that is already a problem with our patient JSL. Now, just to digress a bit by saying that nesiratide is a vasodilator that would worsen blood pressure and perfusion in this patient scenario, so don't attempt to use it in this case. Now, I would also like to emphasize that ionotropes are preferred in patients not presenting with severe hypotension, with dobutamine preferred in those with low blood pressures. Now, severe hypotension with end organ hypoperfusion requires immediate restoration of perfusion with a vasopressor. Now, norepinephrine is preferred over, for example, dopamine, due to the fact that norepinephrine has fewer tendencies to be arrhythmogenic. It has less arrhythmogenicity compared to dopamine, and the need for additional agents for circulatory support are fewer in the case of norepinephrine compared to dopamine. Now, milrinone, on the other hand, is what we classify as a phosphodiesterase inhibitor. It's an ionotrope that causes more vasodilatory and less tachycardic effects than dobutamine. It may be preferred to dobutamine in patients who have been taking beta blockers prior to such an episode. Now, it should be avoided when marginal blood pressure preclude further vasodilation. Just as a by the way, let's move to the next question, please. Mr. GAO, a 57-year-old Hispanic male, presents to the clinic for review. He has a status post recent heart failure related hospitalization, and he has a past medical history of hypertension, chronic kidney disease, and pre-diabetes. Currently, he takes 40 milligrams of lisinopril once daily, 12.5 milligrams of carvedilol twice daily, 40 milligrams of furosemide twice a day, 25 milligrams of spironolactone once daily. This patient reports no symptoms while at rest, and he doesn't have any peripheral edema, so the heart is not doing badly. His weight has remained stable since discharge. He experienced shortness of breath when walking from one end of the hospital to another. Some of the pertinent labs include a creatinine clearance of 45 mL per minute. The potassium levels are at 5 milliequivalents per liter. He has a left ventricular ejection fraction of 63%, with a blood pressure of systolic 139, diastolic 80, and a heart rate of 88 beats per minute. So my question to you is, which of the therapeutic recommendations listed below would be the most appropriate for Mr. GAO? Would you opt to increase furosemide to a dose of 80 milligrams in the morning and 40 milligrams in the afternoon? Or would you double the carvedilol dose to 25 milligrams twice daily? Or would you double the lisinopril dose to 80 milligrams once a day? Or would you opt to administer spironolactone at a dose of 25 milligrams twice daily instead of once a day as previously was? I'll give you 10 seconds to choose the correct mode of intervention. Personally, I would administer carvedilol at a dose of 25 milligrams twice daily. Now, increasing the carvedilol dose would help lower Mr. GAO's heart rate and also improve his blood pressure. Now, such a patient's goal systolic blood pressure should be below 130 as per the ACC/AHA/Heart Failure Society of America Heart Failure Guidelines. Additionally, in heart failure with preserved ejection fraction, such as this patient whose EF is about 63%, lowering the heart rate will allow more time for the ventricles to fill with blood, and this will help improve the patient's symptoms. Now, this patient isn't experiencing volume overload and doesn't have peripheral edema or recent weight gain due to fluid retention, and therefore doesn't need an increase or a doubling of the furosemide dose. Furosemide has no role in his therapy at the moment. On the other hand, increasing spironolactone isn't warranted because this patient's potassium levels are already at 5 and they're on the upper limit of normal. Now, lisinopril, which is an S inhibitor, and ARBs may be used in patients with the HalfRef. However, they don't reduce morbidity or mortality in such patients. Now, increasing or doubling the lisinopril dose would increase the risk of Mr. GAO entering hyperkalemia. Remember, the potassiums are already very high, and the ACE inhibitors tend to cause hyperkalemia. So I would not opt for the lisinopril at all. I would just like to add that in patients with HalfRef, heart failure with preserved ejection fraction and hypertension, optimal blood pressure and heart rate control is important to help reduce symptoms of heart failure. Now, HalfRef patients have what we call a left ventricle ejection fraction above the 50% mark, and they usually present with non-dilated left ventricular chamber. So all that you can see quite clearly on the echo, the 2D echo. So that's just a by the way. Let's move to the next slide, please. You receive a phone call regarding a 66-year-old white male heart failure patient with a reduced ejection fraction. He is in what we call the HalfRef category, and he has apparent diuretic resistance. The edema is worsening. He currently takes a fixed dose combination of sacubitril, valsartan 97/103 twice daily orally, together with metoprolol succinate at a dose of 200 milligrams once a day, and spironolactone at a dose of 25 milligrams after breakfast. He also takes a milligram of bumetanide twice a day, and you are told the lab values are within normal limits. So my question to you is, which of the recommendations listed below would improve this patient's treatment outcomes the most? Would it be changing to torsemide 10 milligrams once daily, or would you consider adding a second diuretic such as chlorthalidone 30 minutes before the bumetanide is administered, or would you encourage the patient to increase his oral fluid intake to hydrate better, or would you change to furosemide at a dose of 60 milligrams once daily? I will give you 10 seconds to choose the correct answer. So I would consider adding a second diuretic such as chlorthalidone 30 minutes before administering the patient's bumetanide tablets. Now, adding a synergistic diuretic which works at an alternative site is the preferred next step prior to hospitalization of such patients with the intention of administering diuretics via the IV route when we have a challenge of diuretic resistance. Now, increasing the oral fluid intake would worsen his edema, so I would not go for alternative C. Fluid restriction is recommended in cases of diuretic resistance, such as in this patient's case. Now, 1 milligram bumetanide is considered equivalent to 20, not 10 milligrams of torsemide. Hence, changing to 10 milligrams of torsemide would be decreasing diuretic effect in this patient. That would not be optimal, neither would it be advisable. Now, furosemide has the lowest bioavailability of the listed diuretics. Now, 40 milligrams of furosemide is considered equivalent to 1 milligram of bumetanide. Now, changing to 60 milligrams of furosemide would be decreasing the diuretic effect in this patient, because remember, he was receiving 1 milligram BD. So it would be slightly underdosing, and there would be a risk of increased fluid retention and edema. So I would not settle for furosemide 60 milligrams once daily either. Now, diuretic resistance is a clinical scenario where patients have an inadequate response to conventionally dosed loop diuretic regimens. Now, the first solution to this problem would be to try and increase the loop diuretic dose. The lowest dose required to achieve euvolemia should be prescribed for managing symptoms of fluid overload in such patients. That's just a by the way. Let's move to this next slide, please. Patient LLL with a hyperlipidemia presents to your cardiac clinic for medication management. He has several medication related issues he would like to have clarified with regard to a new medication he learned about on television called alirocumab. He is aware alirocumab is a PCSK9 inhibitor. So my question to you is, which of the statements below is untrue concerning alirocumab? Is it PCSK9 inhibitors shouldn't be used in statin intolerant patients? Or is it PCSK9 inhibitors lower LDL cholesterol and TGs but they raise HDL? Or is it true that adverse effects of alirocumab include injection site reactions, nasopharyngitis, myalgias, diarrhea, and elevated liver function tests? Or is it true that according to the ACC/AHA lipid guidelines, PCSK9 inhibitors are inappropriate to use in patients with heterozygous familial hypercholesterolemia? I'll give you 10 seconds to choose the correct answer. In my opinion, A would be the correct answer. Now, according to the European lipid guidelines, in patients with statin intolerance, a PCSK9 inhibitor may be considered. Now, the PCSK9 inhibitors are recommended in patients at a very high risk who aren't achieving LDL cholesterol goals despite treatment on maximal tolerated doses of statins with ezetimibe added to their therapy. Now, these PCSK9 inhibitors lower LDL cholesterol by an additional 43 to 64%, according to most forms of literature out there, when they're added to statin therapy. They lower the TGs by like 12 to 17%, but they increase HDL by 4 to approximately 7%. Now, the listed adverse drug reactions do occur with alirocumab use. PCSK inhibitors can be used as an adjunct therapy to maximal tolerated statin therapy in patients with heterozygous and homozygous familial hypercholesterolemia. And I would just like to add that these inhibitors reduce composite cardiovascular events, and this was proven in 2 randomized controlled trials of high-risk secondary prevention patients with clinical atherosclerotic cardiovascular disease. Now, PCSK9 inhibitors allow for more LDL receptors to be recycled to the surface of the cell, thereby increasing the clearance of LDL cholesterol from circulation, and that's the mechanism by which they lower LDL cholesterol quite effectively. That's just a by the way. Let's move to the next question, please. It reads, a 73-year-old Hispanic patient receives treatment from your cardiac clinic regularly. He currently takes hydrochlorothiazide at a dose of 25 milligrams after his breakfast. His average BP is 125 systolic, 78 diastolic, and he reports no side effects from this medication. He is happy with his overall blood pressure control. Now, today's chemistry panel reveals potassium levels of 3.1 milliequivalents per liter, which is a decrease from the previous level of 3.6. So my question to you is, which pharmacological adjustments would be the most appropriate for this patient now? Would you opt to stop the hydrochlorothiazide and initiate chlorthalidone? Or would you stop the hydrochlorothiazide and start a combination of hydrochlorothiazide co-formulated with triamterene at doses of 50/75 per tablet and administer half a tablet once daily? Or would you continue hydrochlorothiazide but add lisinopril 10 milligrams once a day? Or would you continue with the hydrochlorothiazide monotherapy and maintain status quo? I'll give you 10 seconds to choose the correct answer. So I would opt for answer B. I would stop the monotherapy hydrochlorothiazide and substitute it with the fixed dose combination of hydrochlorothiazide and triamterene 50/75. Now, this patient's potassium levels have fallen presumably due to the potassium wasting effect of hydrochlorothiazide. Further intervention to increase the potassium back up to the normal range of 3.5 to 5.5 milliequivalents per liter would be necessary at this juncture. Now, adding a potassium sparing diuretic like triamterene to the hydrochlorothiazide formulated as a fixed dose combination product for convenience would be the most appropriate choice. This patient would adhere better and get better good blood pressure control compared to the other options. Now, adding lisinopril would probably help increase the potassium levels, but given that he is happy with his overall blood pressure control, adding another antihypertensive agent wouldn't be necessary or appropriate as per the patient's wishes. In fact, it would lower his blood pressure further and cause discomfort due to the side effects of a hypotensive state. Now, switching to another thiazide diuretic such as chlorthalidone wouldn't be appropriate, as it would not address this patient's problem, which is potassium wasting. Let's move to the next question, please. In which of the scenarios below would there be an indication for the use of an inotrope? Would it be the presence of tachyarrhythmias while on cardiac monitor in the ICU? Would it be acute diastolic dysfunction causing hypoperfusion to organ systems? Or would it be acute left ventricular systolic dysfunction causing hypoperfusion to an organ system? Or would it be a systolic blood pressure below 110 millimeters of mercury? I'll give you 10 seconds to choose the correct answer. So personally, I'd opt for C. Now, inotropic medications should be utilized in clinical states of lower cardiac output, which include the following: acute left ventricular dilatation or elevated filling pressure. Reduced left ventricular ejection fraction results in a state where LVEF results in low cardiac output, decreased organ perfusion resulting in dysfunction, or a state where the systolic blood pressure is below the 90 mark. Now, diastolic dysfunction could be worsened with an inotropic medication, since there is a degree of actin and myosin interaction. This interaction leads to stronger force of contraction that would affect the oxygen consumption at the myocardium level. So that's just a by the way. Let's move to the next question, which reads: your clinical team is initiating a patient with pulmonary hypertension on epoprostenol. Now, which statements below would be included in his educational session prior to initiating therapy? Would you inform this patient that this medication is infused continuously through a catheter into a vein, or that this medication is sensitive to temperature fluctuations and to light exposure, so it should be stored according to the instructions in the literature insert? Or would you discourage the patient from stopping treatment unless his doctor advises him to, because stopping or changing the dose may bring on the symptoms of their condition and could be dangerous to them? I'll give you 10 seconds to choose the correct answer. In my opinion, all the above are correct. Epoprostenol, which is also marketed as Flolan, is a prostaglandin with peripheral vasodilatory properties. It is indicated in pulmonary hypertension, and it's most commonly administered as a continuous IV infusion using an ambulatory infusion pump connected directly to the central venous catheter access point, and that point should have an inline 0.22 micron filter just to avoid occlusion of the blood vessels. Now it has very specific storage, reconstitution and stability instructions which vary between one brand and another, and I would like to emphasize that generally the mixed solution is stable for 8 to 24 hours depending on the product and the concentration of the solution after admixture. Now the stability times can be prolonged if the temperatures of the reconstituted solution is continuously maintained at the 2 to 8 degrees centigrade range using what we call a cold poach. Now, an unintended interruption in the therapy is not recommended since it could precipitate the symptoms of the pulmonary hypertension. So let's move to the next slide, please. So my next question to you is, which of the vasopressors listed below is the least likely to cause tachyarrhythmias in hypotensive patients? Is it vasopressin, dopamine, isoproterenol, or epinephrine? I'll give you 10 seconds to choose the correct answer. So in my opinion, vasopressin it is. Now vasopressin is the only listed vasopressor in that list that is likely to cause any tachycardia or tachyarrhythmias because it doesn't stimulate the beta 1 receptors like the others do. It works at the V1 receptor level, which is preferentially in the vasculature, not on the heart. So let's move to the next slide, please. The question reads, with which of the following ARBs has sprue-like enteropathy been reported? Has it been reported in the case of the use of olmesartan, telmisartan, valsartan, or losartan? I'll give you 10 seconds to choose the correct answer. So olmesartan it is. Severe chronic diarrhea with substantial loss of weight has been reported in patients taking olmesartan even months or years after drug initiation. So intestinal biopsies of patients often demonstrate villus atrophy in such cases, and if a patient develops such symptoms during treatment with olmesartan, we should endeavor to exclude other etiologies and consider discontinuing the olmesartan therapy in case there is no other etiology identified as the cause of the diarrhea and those other symptoms. Let's move to the next slide, please. A 77-year-old white male patient is brought to your cardiac clinic with a new onset of atrial fibrillation. He has a past medical history of coronary artery disease, status post-MI, which he has had twice. He has a heart failure with a left ventricular ejection fraction of 30%, and his dyslipidemic. Now, the clinical team opts to use pharmacologic therapy to achieve rhythm control in the case of this patient. So my question to you is, which of the antiarrhythmic agents listed below would be the most appropriate for this patient? Would it be sotalol, amiodarone, procainamide, or flecainide? I'll give you 10 seconds to choose the correct answer. So in my opinion, amiodarone it is. Now, amiodarone is the only listed agent that is considered ideal for patients with low LVEF in need of an atrial stabilizing agent that hasn't been shown to worsen mortality in the case of post-MI trials that have been carried out. Now, class 1A agents, on the other hand, such as quinidine and procainamide, and the class 1C agents such as flecainide and propafenone, and some of the class 3 agents such as sotalol, when used in patients with low left ventricular ejection fractions, can be proarrhythmic. So it would be dangerous to use them without caution. And they have negative inotropic effects and have been shown to worsen mortality in the so-called post-MI trials. This brings us to the end of part 35 of our pharmacotherapy MCQ series. If this video helped you in any way, I would like to remind you to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I would like to humbly ask you to subscribe to my YouTube channel. I would like to say that I'm very thankful for your continual cooperation and support. And I would like to promise you that the best is yet to come. I would like to sincerely thank you for viewing and for listening to this video. And I look forward to interacting with you in part 36 of the Pharmacotherapy MCQ series. Thank you for always being there for me.